palliative care, hospice care, home health, and discuss those services available to you in all levels of care. Now, as you know, the ARC does not have a home health agency or a hospice agency, so we collaborate with many agencies in the community, and we put out flyers in the front of some of the hospice agencies that come to our campus. You are free to use any hospice that you want to. Just like it's a Medicare benefit, so you can choose whatever hospice you want to. Only in healthcare, we have to have a contract with that hospice, but anywhere else, it doesn't matter. You can use anybody. So at first, we're going to watch a short video about palliative care. Should we hit the lights?
You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter, cracks appear, and pretty soon it's hard to withstand all that traffic. Traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care, specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge. And when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists, all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So, next time someone you care about is facing a serious illness, remember this bridge analogy, and be sure to consider the enormous potential of palliative care.
Thank you. The one thing that we all have in common, we could watch that too, we'll talk more about it. The one thing that we all have in common is that one day we will all pass away. And the palliative approach, the hospice approach, is the goal of those approaches is to make the end of our lives quality, not quantity. How many of you have had loved ones that had hospice care? So many of you. So you're familiar as a caregiver, family member, on what hospice can provide for you and your family. Now, Medicare pays for hospice. And to qualify for hospice, I'm going to have Enrique talk about some disease processes that would qualify you for hospice. Failure to thrive is not an accepted diagnosis anymore.
Hi, good morning. Yes, mostly it is that if you have a diagnosis of 6 months or less to live, or there is an uncontrollable illness or an uncontrollable illness that cannot be managed. So they going through a process of an evaluation by the hospice of your choice. They come over and evaluate your loved one, yourself, who you want to be on hospice for your choice. And then they decide to see if that will qualify and your insurance will pay for it. And they do pay for the service itself, but they do not pay for the board and room and board. Sometimes we get confused about it. So what covers mostly is that you'll have a registered nurse coming in, I believe it's 1 to 3 times a week, and see your loved one. They have also a shower aide, CNA, Certified Nursing Assistant, coming over to as well to shower, assist in any things that the resident may need. Have a chaplain, a spiritual, of course, to support that. And the best thing about it is that you have an extra pair of eyes that to make sure that if there's something that needs to be addressed is directed by not only the nursing staff over at healthcare, but also a nurse that is coming in to see them regularly. So it'd be the registered nurse that's consult with the doctor, with their hospice doctor, and then they of course, they make sure that your loved one is taken care of, free of pain, comfortable. That's the goal for it, to make sure they're comfortable and
Thank you, Enrique. So when you start on hospice services, you have, a physician has to certify you, certify that you need hospice, that you may pass away within 6 months. So the first period of certification is 90 days. So hospice will start their 90 days, and after 90 days, they come and recertify you. The physician will look at your progress, see how you're doing, and if you still need hospice, because some people graduate from hospice, then they will recertify you for 60 more days and 60 more days and 60 more days. So we've had many people that have graduated from hospice because whatever chronic illness that qualified them has been stabilized. I'll tell you a story. I have two residents over in a part of our building, and they wanted to get on hospice because they were ready to go. They didn't really have anything that was going to anything they were going to die from, but they just wanted to go. So they both got on hospice, and well, I'm not dead yet. The first day, second day, well, I'm still alive. I stopped eating, but I'm gonna start eating again. So by the third day, they both got off hospice because they realized that hospice is not there to euthanize you. Hospice is there to support you. So when a person goes on hospice, as Enrique said, it could be recommended by your physician. The physician may order hospice. You may know of a hospice that you've worked with. You may ask one of us about a hospice recommendation. We cannot tell you which hospice to use. You have a choice. So we'll give you a list. If you're in healthcare, we'll give you a list of everybody that we have contracted. Or we can do a special contract one time if you have a hospice you really like and want to use. In assisted living, there is no contract with the ARC to provide services. And I'm going to have, Rachel is our AL manager here at Lakeside, and she's going to talk a little bit about hospice and assisted living.
Okay, so one of the things with hospice, or that I feel is benefit from hospice, is that you have an extra pair of eyes that comes out to manage your long-term illness. And a lot of the things that they work on is pain management. So they do come out, I've seen them come out just for music therapy, sometimes just someone to talk to. They'll send out the social worker. They're there to just support you in any way. I've also even seen them do physical therapy with the patients. So hospice can be utilized pretty much in all different types of aspects, like just extra care. So not only, do you have us, the staff here at the ARC, but then you have outside staff coming in and kind of just keeping an eye out as well. And so we communicate together to kind of resolve your end-of-life illness.
Now, Rachel, if I want to go, some people believe that you can't go to the hospital if you're on hospice. Is that true?
No, you pretty much, yes, you can go.
You will be discharged from hospice because your Medicare A is paying for hospice. And they will pay for hospice and your hospital stay. So say if somebody's in hospice, they break their leg, well, they need to get that fixed. So they go to the hospital, they discharge from hospice, go to the hospital, and then come back and either get on hospice or they can have rehab. Because the same pot of money that pays for your hospice pays for your Medicare A stay or rehab stay in the facility, in the skilled nursing facility. What else? Another thing that hospice provides are supplies and medications that are tied to the terminal diagnosis. So for instance, hospice will bring in incontinence care, they'll bring in, what else?
Wound care, the bed, oxygen tank, everything you need to come to pretty much provide comfort.
Yeah, and that's anywhere. That's in independent living, assisted living, home, even in skilled nursing, they'll bring those items in. And typically, you get the services of a CNA. So the CNA, if you need assistance in bathing, they will come in 3 times a week and help you with your personal care. So that's a great benefit of hospice.
And you get a lot of one-on-one, and I see that's one of
Yeah.
the main things that you do get from hospice, where you have
Now-
that one-on-one care.
Rachel, do I keep my own physician or do I use the hospice physician?
You can still use the primary physician, and they're in contact as well with the hospice physician.
Okay. So not only do you have an RN coming to check on you on a weekly basis, and if you're unstable, sometimes it's every day, you have a hospice doctor that's looking at your records. They have stand-up meetings and care plan meetings too. So in their office, they're talking about how Enrique's doing on hospice and what he needs, and if he still qualifies for hospice. So it's a pretty involved process, but it's very beneficial. Now, the reason I show the palliative care, you do not have to get on hospice to have palliative care or end-of-life care. Those type of treatment plans can be done without hospice. Some people believe that getting on hospice, say if you're in the skilled nursing, is double dipping. Is that, okay, all this is provided by the ARC, why do I need you to come in to bathe me? And so those folks may choose not to have hospice and just go on a palliative care plan. And that often includes stopping some of your medications. Certainly, we're going to be more liberal in terms of diet. So if a diabetic wants palliative care and wants cake every day, well, you can have it. We'll just watch your insulin and your blood sugars. So palliative care is available without hospice. Now, when you are on hospice, you're going to get an explanation of benefits, just like you do now if you go to the doctor's appointment or something like that. So Medicare, or your medical insurance, pays hospice a bucket of money each month to cover all your care. That's how the supplies, the medication, the aides, the nurses, that's how they pay for those services. And so it is, and it is generally between $4,000 and $5,000 a month. But that's a lot to cover, nursing visits and things like that. Now, okay, Enrique's on hospice, and he's experiencing lots of pain that can't be controlled. He's really needs more than just what we can provide, or he can get in his home. So they have inpatient. You can go in, hospice agencies have an inpatient. I know that Vitas has a unit on the medical center, and other hospices have different places that they contract with for you to go in just for 3 or 4 days to get your symptoms under control. And that sometimes, it doesn't really happen a lot here because we can manage that ourselves, but especially if you're at home and you need that extra support, that extra monitoring, you need a doctor to see you every day to get your symptoms under control, they have inpatient hospice. Hospice also provides respite. So you're at home, Enrique's at home, and his wife is burned out. And she needs to go on a trip, or she has things that she needs to do. So Enrique can do a 5-day respite somewhere. Hospice agencies will have a contract, generally with a nursing facility or with an assisted living, or they may have a unit of their own where Enrique can go for 5 days, hospice pays for it, and then his caregiver can get some time off. And that could be done, you can do 5 days and then you have to go home 2 days, you can do another 5 days. So that's a benefit that some people aren't aware of. And then this is not done as much now. It used to be, since I'm an old timer, it used to be that hospice agencies would come and do crisis care, meaning they would have a staff 24/7 bedside for someone who may be actively dying or needs those extra eyes to make sure you're doing okay. So that's called crisis care. Okay, Rachel, did I forget anything? No. I didn't, okay.
Sometimes there's confusion about whether you can get aggressive medical interventions from hospice.
So,
What's the question?
sometimes there's a confusion about getting curative or aggressive medical intervention while under hospice. And that, there's many situations where, well, like we mentioned, they'll do some physical therapy and things like that. But if you do need aggressive curative intervention, then that would be the time to discharge from hospice, maybe go to the hospital or whatever, and then get back on. You can have antibiotics on hospice. You can have IVs on hospice. Probably not chemotherapy, unless it's palliative, unless it's relieving a symptom that you're having.
Sometimes family members don't understand.
Yeah, sometimes, family members don't understand it. So, like I said, these two residents thought it was euthanasia. Well, it isn't, it's support. And so, most, the hospice doctor will determine whether this intervention is needed. They'll provide it either through the hospice agency or like an IV or something that they can do at home. But if more is needed and you want more intervention or more curative, then that's when you discharge from hospice and get those services elsewhere. Yes, ma'am.
If you're on hospice and you get to the point that
This
you
is like-
ignore the hospice, does the ARC, the nursing staff doesn't do IVs, so the hospice nurse comes in and does the IVs if you need IV meds?
Yeah, they will do that if it's necessary. It has to be an approval process from hospice to approve IVs. Usually they do not, but that's the case to
What
case.
about IV morphine?
Oh,
Yes.
that'll be good.
Yeah.
We'll-
Typically, the morphine is sublingual.
Sometimes.
Yeah, sometimes it's not.
Yeah.
But we do IVs in the skilled nursing. So we've had people from independent living, from assisted living that need IV treatment. And they'll come to healthcare for a short-term basis to get those IVs, and then they go home.
Who monitors that then? Who monitors the IV?
If they're in the healthcare, then we do, the nursing staff, yes. They're all IV certified, and we have a group called PICC line, PICC. And they'll come in and help us train and give the expertise on maintaining the PICC line for your IV drugs. Sure. Yeah, it's come a long way. It's come a long way. So, but as I said, you may not want hospice. There are people on hospice that do not have a do not resuscitate order. So they're ready for the benefit of hospice. They know that they need the support of hospice, but they still want to be resuscitated. So you do not have to have a DNR to be on hospice. Yeah, some have been on hospice. Gosh, I've known some people that have been on hospice 5 years. And they changed the regulation in terms of the certification. The certification is more often now, the 60 days. So they're really monitoring people so that the hospice benefit is not abused. But I know we have someone who's 100 over at Crestway, and she's been on and off hospice for 10 years. She's off it right now. So that's something that you can go on and go off. Yeah, things are unpredictable. Some people just, we don't know. For instance, if you come in for a skilled stay and you're at Lakeside, but we don't know whether you can go back. So what we do is we monitor, see how you're progressing in therapy, and a lot of folks are able to get better and go back to their prior level of functioning and go back to where they were living. So I'm going to talk a little bit about home health. So we don't use a lot of home health here at the ARC. That is also a Medicare benefit, and if you qualify for home health, it means that you could qualify for a skilled stay. You have to be homebound. So whereas hospice, you can, kind of run around a little bit, but with home health, you cannot run the streets, so to speak. You can't run the streets if you're on a skilled stay in the SNF too. So if somebody comes and they're on short-term rehab, well, I need to go to the forum and I need to go do this and do that, and I'm going to Water's Edge and things like that. So Medicare, just like with the ARC here with the SNF, they feel like, well, if you're doing all this, you don't need home health. You can take care of yourself. So there's some rules about home health. Home health provides physical therapy, occupational therapy, speech therapy, as well as nursing care. Typically, when you're on home health, the nursing care involves, it could be IV, but typically it's wound care.
Medication management.
Yes, medication management. It's very important that when you, say you go to the hospital and you choose to have home health, that there is the handoff from the hospital to the home health is strong, because if you get home, you don't have your meds, you don't have a doctor's appointment to get your meds, then you're more likely to go back to the hospital. We call that a readmission. And we strive to do the same thing here. If you're here at the ARC for a short-term stay, we want to make sure that your transition back home is successful. That's why we go and do a home visit with a therapy group. We make sure you have medications or scripts for your medications, so that when you do go home, you're successful. Now, many of you don't choose home health, I believe, here at the ARC because our therapy team is so good. So you can't go upstairs to John's therapy and get Part B therapy and be on home health. But if you do need the nursing, you do need medication management, you do need these other things, it would be better for you to go on home health temporarily, and then you can go upstairs to the gym after your discharge from home health. Make sense? It's complicated, I know. Okay. So your handout, I just did. This is from the state, and I've got some information from Centers for Medicare and Medicaid, CMS. This talks about what hospice care provides, what palliative care provides. The thing they have in common, you really can't read that. And I anyway, it's just a little comparison. On hospice care. Now, another, something else I wanted to point out, when we did talk about hospice supplying medications and things tied to your terminal diagnosis, they have to give you a list of medications that they're going to cover and not cover. You have a right to that list. So when you're in, say you're on hospice in healthcare, Enrique, what typically would hospice cover and what won't they cover?
Yes, what they usually cover is the blood pressure medications, the bowel management medications, the thyroid medications
Yeah.
as well, pain medications as well. But the others, they may not. Sometimes the high cholesterol medicines, maybe they do not. Mine may not. Depends also on the diagnosis that we were admitted on hospice.
Yes. And
Sorry.
so the medication, what Enrique was saying is that they'll cover like blood pressure, thyroid. They might not cover your statin, your cholesterol medication. They're not going to cover your vitamins. They're not going to probably no OTCs. But the main thing is they're going to cover your pain medications and
Bowel management
and bowel management.
and medications.
Yeah, because a lot of folks that are on pain meds have constipation, and so they will manage those symptoms as well. So Debbie, just 2 seconds. Hospice in independent living.
Hospice and independent living, we don't hear of it too often, but it is an option for you. You can certainly have your hospice agency in your own unit, and we will do whatever we can to support you as well. One thing I did want to make mention of earlier when Suzanne was mentioning home health too.
Speak up.
Speak up. One thing that I did want to mention is it's a good reminder, if you have a procedure and you're going out to the hospital, please make sure that you check in with the front desk and give them some advance notification. That's very important because sometimes your length of stay may not be what you anticipated, or there may be complications. And we want to be able to track you while you're in the hospital. Bernie, our clinical liaison, tracks all residents in independent living that we know of. They're in any local facility. And that way, when the case manager is ready to discharge you, we too are ready with you either going to SNF in healthcare or coming back to your unit. And we know if you're going to be on home health, what is necessary. Do you need O2? Do you need companion services? Maybe some other ancillary items that we can help support you with to make sure that your recovery is positive. Typically though, be mindful that if you do elect to have home health, they only come in for given windows of time, and it's short windows of time. It could be maybe an hour to an hour and a half, maybe 3 days a week. So if you're fragile, if you don't feel as though you can manage at home, the best idea might be to go directly to healthcare to get that support from the nursing team, and make sure that you have a positive recovery going forward so you can go back to your unit and have an enhanced quality of life once again. It's very important. The other thing too is if you notify resident services, we're always very appreciative so that our team can be equipped and be ready and on site for you when you are discharged and know what your needs are immediately instead of scrambling. It's always very helpful. But back to hospice, you're more than able and willing, and it is your option and choice to have hospice in your own unit. And many times over the years, I can tell you that residents have opted to have hospice at home with their loved ones.
Thank you, Debbie. And thanks for pointing out about the limitations of home health. It is not 24/7, and neither is hospice 24/7. It's being paid for by your Medicare, which is medical insurance. So they will pay for things that are skilled, like your nursing visits, your therapy visits, all those things. But they do not pay for 24-hour custodial care anywhere. Just like if you're in a short-term stay at the SNF, they pay for your custodial care because you're getting skilled care. Once the skilled care is no longer necessary, or if you're not improving with the rehab and things like that, and you get discharged, then you go into a private pay situation here. So we do have TRICARE for Life, and we have 4 or 5 residents that have used up all their Medicare days, and they're on TRICARE for Life, and they get the same therapy benefit as they did on Medicare. And we pay for all the medications, transportation, and things like that of our residents that are on TRICARE. And we've had somebody that's been on 400 days. Yeah, so that's something. Yes, sir.
Over here. I like it. Excuse me.
If you're on private pay status, if you get to that point and you have long-term health insurance, how are those claims handled?
We handle those claims through the finance office and our office. So I want to introduce Valerie Flores. She's one. Stand up, Valerie. She's our new office admin in healthcare, and she's been with us 3 months. And Enrique and Valerie just sent off a bunch of documentation for long-term care insurance. So what we do is we have to fill out assessments periodically, medical assessments, and then we send your monthly bill to, after it's, like we just sent July's bill to the long-term care company, and then they pay you for that month. And they ask us if you were gone. So if you were in the hospital, we have to say, okay, Enrique was in the hospital 5 days, so they won't pay for those 5 days because he was not in healthcare, in his bed, so to speak. So, we probably have 20 at least on long-term care insurance. Yeah. And the policies vary, so it just depends upon your benefit in terms of what it's gonna pay on a monthly basis. We have a lot of people on long-term care and assisted living as well,
Yeah, okay.
so we monitor that. What else? Yes, ma'am.
I just wondered, they used to be limited on the number of Medicare, they used to be, had a few Medicare beds, and you would have to wait to get in those beds. Is that still true?
No, that is not true. 100% of our beds in healthcare are Medicare certified. So you can go into any bed, whether it's in the Oaks, A-Wing, B-Wing, and receive rehab services. So all the beds are certified, and they have been for about 2 years now. So we have plenty of availability. I think we have 17 in skill days right now.
Yeah.
Something like that, yeah, it's about 17. And so, and of course, just a reminder, your Medicare benefit, it's 100 days. First 20 days are paid 100% by Medicare, and then the next 80 days is 80% by Medicare and 20% by your secondary, which is generally TRICARE for life.
Those people that are going on hospice for the first time, the loved ones, they tell you everything they do, but they don't explain all the details. Like,
Yeah.
you will never see the doctor that's managing your care.
Right, that's
And
correct.
I had a nurse that was assigned to my husband,
Mhm.
and she threw away a bunch of opioid medicine she didn't think we should have.
Oh.
So naturally, I would not recommend
Yeah.
that particular hospice group. but-
That's true. Yeah, and they do bring,
The ones we partnered with.
yeah, we get a lot of feedback, and we're watching them. You know, we have, from our hospice agencies that we use, and we monitor them as well. And again, their primary care physician still follows them, and they see the primary care physician. That nurse is calling the hospice doctor for orders, and you're right, that hospice doctor may have never laid eyes on your loved one. So I believe that Dr. Givens still is one of the
Yeah, Dr. Givens, for one of them.
Gentiva, I believe, yeah. So she still follows, so if you have Dr. Givens, she'll follow you as a hospice, in the hospice. One of our other doctors, Dr. Moskowitz, is a medical director at Vitas. So he, if you choose Vitas, he may follow you on Vitas. We use, Hope Hospice. They're a not-for-profit based in New Braunfels. And so they're, in the old days, I like to use because I prefer not-for-profit. And Santa Rosa was one. Blue Skies has a hospice, and we have one person on Blue Skies Hospice. But they just started going off campus, so they're a little bit limited. He was referred to Blue Skies Hospice from the VA, but that's his choice, and that's that's the family's choice.
I think this gentleman had a, didn't you
Question?
have
Let me go ahead.
Just a question.
Yes, my question has to do with reimbursement. You can do palliative care, not be on hospice, you can go on hospice for the additional services. How does it impact your room and board reimbursement? Because hospice generally doesn't, in the past, did not pay room and board. So there is some impact on your reimbursement. I'm curious as to what that is.
So it impacts our reimbursement indirectly. So if they're bringing in incontinence supplies and different things, then we don't have to. If their aide is coming in to bathe, then we don't spend the labor to bathe you. But in terms of palliative care, it's your private pay. And it doesn't affect, if we do a palliative care plan, the doctor, your physician, primary care physician, does the care plan, and it really doesn't affect our reimbursement.
You had a question about monitoring hospices, the nurses that come over to visit our residents, is that they are required to meet with the director of nurses or myself about the care that was provided for them the particular day they come over. So we are monitoring them very closely as well. Yes, it makes sense,
Yeah.
that makes sense that what the medication or any changes they have done, especially the psychotropics and narcotics.
Yeah. Well, and sometimes it just depends on the team and not the company. I worked in Bernie for 8 years, and we had hospices that were wonderful out there. It was a different team. And then come to the ARC, and they have a different team, and they're not so good. So sometimes it's the staff and not the company that's that we have to consider.
So the oversight that Rick was mentioning is really in our healthcare center. And
Yeah, the
Resident
oversight,
Services
yeah.
is kind of that liaison, IL, but we don't quite have that.
Right. Yeah, because
They can assist a few challenges.
their hospice is a guest in our facility. They're a guest here in assisted living. So we closely monitor what they are doing. They have to sign in, they have to do paperwork. If a CNA comes and bathes, so I've had this happen before. A CNA comes in and gives somebody a bath and causes a skin tear, but didn't tell the nurse. So we discover the skin tear, and then we don't know how they got the skin tear because they didn't report it. So if we have things like that happening, then we will encourage the family to change hospice agencies. We'll go to that hospice agency and discuss those things with them. But we do, in the licensed areas, monitor the hospice staff. The clergy, that is another, we didn't discuss that, but that's another big benefit of hospice. So the clergy, they all have to employ a chaplain, and they come in and visit with the families, as does a social worker, as do volunteers. If you have a hospice agreement with CMS, you have to have volunteers, a certain number of hours of volunteers. Yesterday, we had this fabulous carnival in healthcare that was organized by Activities. And we collaborated with some of the hospice agencies that come into the ARC. So Good Shepherd, Vitas, Heart to Heart, Gentiva, and Guiding Light all came in. They brought prizes, food, a goat, games. They provided, we had a raffle, they provided those prizes. And so it was the residents had a great time. It's on the Facebook page, I believe. And we're starting to do collaborative activities with staff and residents on a monthly basis. So the staff was there, we had great pretzels from the kitchen and popcorn machine, games, pie in the face, those kind. And as the weather turns, we'll do some more outdoor celebrations. We're gonna have a high tea, but it's a good chance to get hospice to support us and really support the residents. They also provide education. So hospice agencies have folks that will come and give presentations on end-of-life care, on med management, on dementia, and this is to the staff. There's a number of things that they'll come in and do. Rachel, you've had them come and do some things.
It was dementia training, and they also help support for Nurses Week, CNA Week. The employees are very happy with that. They give back a lot to our community.
Yeah, they really, yeah, they do give out. That one hospice comes every 2 weeks and brings all these snacks, and we put them out on the nurses station. So it's really collaborative, and they do support our staff. And if a hospice does it and they expect a lot of referrals, well, they might not get them. I'm not saying bribes. We're not bribed. We don't want to be bribed, but we do want a healthy collaboration between whatever hospice providers are coming into our building. And
why don't we have our in-house, within-house hospice? But
Um,
you run, but we just say, we want to go on hospice and it's
Yeah.
run by the arc.
The short answer to that is that we don't have enough lives. We don't have enough people, a pool of people. So that's why, for instance, Blue Skies went off campus because they needed more business. They needed a larger market. So we wouldn't have enough folks for a home health or a hospice. That's why when we're in our continuum of care meetings, we're talking about collaborations that we can have with other providers, vendors, whatever, home health, personal care, all those things, how we can collaborate with them to help you remain in your age in place, remain in your IL apartment. Because you could have a choice. Yeah, safely. So that's one part of the strategic plan, and Debbie and I are on that task force, as is Ms. Taylor and some others. What else was I think of? I don't know. Questions, anything? Oh, yeah, crisis care. So if you have, your symptoms are being unmanaged, hospice will come in and provide intervention, crisis care. They'll send staff in, or you may go to their inpatient unit. As I said, Vitas has an inpatient unit in the medical center. And so you may go there, you may come back. There are some hospices that are facility-based. There's one called Abode, and it's a small hospice. It's a not-for-profit. I've never been there, but it's supposed to be excellent. So you can go and live there your last month days, and they take care of you and your to make sure that you have quality of life. It's all about quality, not necessarily quantity. Oh, imminent. Yeah. So if somebody's imminent, say in healthcare, the nurse is coming in sometimes several times a day, once a day, so that they are there for you, there for the resident, to make sure that symptoms are being managed. And they provide, the clergy will come in, sometimes they'll give last rites, social worker will come in and collaborate with the family, the last 3-5 days that they're with us.
That's a question.
We're not able to hear people's questions in the audience,
Okay.
and so I think it would be very helpful, at least to me, if you would repeat the question that they
Sure.
asked you,
Yes.
Okay.
and also the answer.
Okay.
Thank you.
Will do. Thank you, Ms. Monsi.
Thank you. Anyone else?
Anyone else?
Any question about healthcare or any other thing you're curious about?
A lot of questions.
Yes, sir.
Some of us do not have TRICARE, but do have long-term care that we pay for. How does that tie in?
Okay. Sure. So long-term care does not pay for hospice services. It pays for custodial care. If your secondary is not TRICARE, that's okay. It could be something else. Now, one thing that will happen, if you're on a Medicare Advantage or you're on some other Medicare replacement, you will go to traditional Medicare. The hospice, you go back to traditional Medicare, then the hospice bills traditional Medicare. So that's something it's a little bit different. So the Medicare Advantage plans, it works a bit different, and that you'll probably go off the Medicare Advantage and revert back to traditional Medicare while on hospice.
But just in general, long-term care insurance,
Yeah.
they pay privately, then they can reimburse.
Yeah, it's your long-term care insurance reimburses you for your private pay for. So, and that's, after the fact. So they'll give you a check after you've, like, as I said, we're sending out bills for July. then the family members will get a check, in a couple of weeks to cover that time. Yes.
This is great information. I think it's information that all of us that move to the ARC need. Is there a source that we can go to here at the ARC, either on paper or the portal or someplace that we can see this detail? Because I know for one, I can't remember all this.
Sure, well,
So-
and I don't have all the details either, and I'm in the business, but yes, this is gonna be on the portal, this presentation.
Good.
Certainly you saw all the brochures, and a lot of the information in the brochures is general information about hospice. I did not invite a hospice company to present because it's an advertisement most of the time. We wanted to give you more objective information about hospice and how the ARC collaborates with Hospice Home Health and those entities.
And I would say in healthcare, we have a social worker that's full-time. Just in healthcare, we have a social worker that's full-time that could be a resource. And really, Debbie Resident Services can be a resource as well on hospice education and the intricacies.
And I've got some general handouts from Medicare.gov on hospice and home health, and we'll put these in the portal as well. And a legible copy of this too. But hospice is fairly new to the world. It's 50 years old, but it's a good, I think it's very beneficial for families and certainly the patients to have those services. And you pay for them through your Medicare. You're eligible and you deserve them if you want to. I know of a doctor, a very prominent physician in San Antonio, who won't prescribe hospice because he thinks it's duplication of services. But those are few and far between. But as a provider, as a nursing home administrator, we certainly appreciate what they do for our residents, our families, and also for our staff. It's a great collaboration. Anything? Nothing? Yeah. Next time we have a big carnival, we'll invite you. It was a lot of fun. It was a lot of fun, and we have, not only do they bring, they'll bring in service animals, they'll bring in other things that to entertain and to support our residents as well. Some of the hospice companies.
Can I just make a comment about Archangels too?
Oh, gosh,
Archangels
yes.
is a fantastic group of people, residents here in our community that support and truly enhance the lives of residents in our healthcare area. If you would like to become a volunteer in any way, please stop by our office. I know Archangels is reinitiating themselves, if you will. During COVID, we really had to abandon that service for our healthcare residents. But we're trying to reinstate it, and we would really like some volunteers with the juice carts and hand out snacks, and I think we're even going to try to expand even more so into our assisted living areas. So if you're interested at all in spending, an hour a week or, any dedicated time, please come by our office or come by Suzanne's office and let us know, okay? Thank you. 307. Next to the mail.
Yeah, and you can always call 5200, that's our number in healthcare, or if you call 5300, they will find us. They know our cell phone numbers and things like that. So if you can't get somebody on the phone in healthcare, or you have questions, call 5200 or 5300. They're looking at us through those cameras walking around.
And one other note, if you haven't read your resident update that was distributed yesterday afternoon, we are going to be offering our annual flu vaccine in Heroes Hall. If you'd like to sign up, there are sign-up sheets on the activities board from 9 to noon on October the 3rd. And we'll be putting out more information about that as well. But October 3rd from 9 to noon in Heroes Hall this time. And you will need to sign up because we need to get consent forms out to you in the very near future.
And Debbie, will that be the senior shots?
This is the flu shot.
Yeah,
No,
this,
I know.
the senior shots.
The senior shots.
That's correct.
Okay.
65 and older.
Right.
And there's also a presentation next week concerning, BAMC's coming in next week. What day? Tuesday at 10 o'clock.
At 10.
And where is that being held?
Right here.
Okay.
In the theater. Colonel Yoon from BAMC will be here to discuss services provided by BAMC, how to navigate through the military system. She'll talk about PCPs and how to schedule maybe outpatient surgeries and procedures as well. I think it'll be a very good, informative, and educational presentation, and they haven't been out here for almost 3 or 4 years, actually. So I think it'll be really good because they have changed their system. She'll also talk about the Genesis program on the computer, how to navigate that, and getting appointments, which is very, very complicated. So it would be really good if you all could attend that particular presentation.
And that's going to be filmed as well. That will be filmed. Well, if there's, it isn't anything else, finally cool down in here. Yeah, I know that we're leaving.
Exactly, nothing really, it's just that. The Good Shepherd Hospice, are they the same Good Shepherd that runs out of South Dakota? They have a multitude of senior.
You know, I have to look on there, probably. Is it Good Samaritan? Oh,
Because Good Samaritan is, yeah.
yeah.
We've been under their care before.
Okay. Oh, wow. Okay. And Healthcare Today, it's Hawaii Day in remembrance of those victims of the fires in Maui. So, yeah. Okay. Yeah, we'll be here for a while if you have any questions. We're available. Call us 5-300-5200, and hopefully, if we don't have that answer, we'll get it for you. Thank you.